This is Schizophrenia, Spectrum, and Other Psychotic Disorders recap from Chapter 11 of the PMHMP, Review and Resource Manual 4th edition. I spend a lot less time on graphics, and I just want this to be more of a listening presentation, something that I can hear when I'm driving and replay. So here it is. This chapter describes a category of severe mental illnesses that have a researched biological basis to the other disorders. Schizophrenia, the prototypic disorder of this category of illnesses, is multifaceted and affects a person's ability to function in many spheres of daily life. Of the psychotic disorders, schizophrenia is the illness that has been heavily researched and the one we know most about. General description of psychotic disorders. These brain-based psychiatric disorders are grouped together because of similarity in frequent psychotic symptoms. Each disorder has a different etiology. Psychotic disorders are some of the most debilitating classes of psychiatric disorders as determined by the degree of functional impairment and financial burden of severe mental illness. Psychotic implies the inability to test reality. Manifests in symptoms such as hallucinations, delusions, disorganized speech or thinking, referential thinking, abnormal motor behavior, and negative symptoms. Psychotic disorders are generally known to have a strong genetic component. Hallucinations are false sensory experiences without a stimuli being present. They're arranged in order of commonality, starting with auditory, and then second most common is visual, tactile, olfactory, and gustatory. With a special note of hypnagogic hallucinations being a false perception that occurs when a person is falling asleep, and hypnopompic is a false perception that occurs when the person is waking up. And then delusions are a false belief firmly maintained despite evidence to the contrary. They can be persecutory, religious, grandiose, and we're going to talk about those in a moment. Disorganized thinking, often referred to as formal thought disturbance or thought disorder. So disorganized thinking are problems with information organization and interpretation that is best assessed in the speech patterns of clients. So disorganized thinking is best assessed in the speech pattern of clients. Some examples are loose associations, derailment, tangentiality, and word salad. Disorganized behavior is unusual behavior ranging from childlike silliness to anger. Referential thinking and delusions of control are beliefs that events, action, or situations in the environment hold special significance or meaning. Some examples would be thought insertion, withdrawal, thought control, and thought broadcasting. And this is referential thinking. Illusions are misconception of an actual environmental stimuli. So an illusion is there's an actual stimuli present, but it's a misconception of an actual stimuli. We'll start with schizophrenia. Schizophrenia causes significant disturbance in many areas of functioning, such as cognition, perception, emotion, behavior, eye movement, and socialization. The etiology of schizophrenia. Multiple theories exist, ranging from psychological to neurobiological. The etiological profile is probably multifactorial. The neurobiological theory implicates three areas of neurobiological functioning: genetics, neurodevelopment, and neurobiological defects. Genetics. Studies of twins have identified schizophrenia as having a strong genetic component. The incidence increases from 1% risk of illness in the general population to 50% risk in monozygote twins of persons with schizophrenia, 15% risk for dizygote twins of persons with schizophrenia, and 40% risk in children if both parents have schizophrenia. No one specific gene has yet been identified. A polygenic SNP defect is believed to exist. Chromosomes 6p24 through 22 have been implicated. Neurodevelopment. Genetic defects are believed to cause abnormal neuronal cell development, connection, organization, and migration. These include inadequate synapse formation, excessive pruning of synapses, and excitotoxic death of neurons. Intrauterine insults may contribute to the etiological picture. prenatal exposure to toxins, including viral agents, oxygen deprivation, and maternal malnutrition, substance use, or other illnesses. Neurobiological defect. Several abnormal brain structures have been identified in people with schizophrenia. Smaller frontal and temporal lobes, reduced symmetry in temporal, frontal, and occipital lobes, cortical atrophy, decreased cerebral blood flow, hippocampal and amygdala reduction, and enlarged ventricles. So everything was small, less, or decreased, except the ventricles are enlarged. Smaller frontal and temporal lobes, reduced symmetry in the temporal, frontal, and occipital lobes. However, there are enlarged ventricles. These abnormalities lead to suspected impaired neuronal communication, suspected alterations in chemical neuronal signal transmission, excess dopamine in the mesolimbic pathway, decreased dopamine in the mesocortical pathway. There's excess glutamate. There's decreased GABA and decreased serotonin. So I'm going to repeat that. Abnormalities lead to suspected impaired neuronal communication. Suspected alterations in chemical neuronal signal transmission in schizophrenia are excess dopamine in the mesolimbic pathway, decreased dopamine in the mesocortical pathway, excess glutamate, decreased GABA, and decreased serotonin. Incidence and demographics. Geographic and historical variations in incidence give insight into ideological factors. Higher rates are seen in urban-born, firstborn, lower socioeconomic status, born in winter and early spring. Schizophrenia tends to occur less often in women than in men. The onset for men of schizophrenia is 18 to 25. They tend to have more negative symptoms than women. They tend to have poorer prognosis and more hospitalizations and less responsiveness to medication than women. Women age of onset is 25 to 35. They usually have less premorbid dysfunction than men, usually experience more dysphoria than men, and we'll let that announcement finish. Okay. They usually experience more dysphoria than men. They tend to have paranoid delusions and more hallucinations than men. The age of onset has pathophysiological and prognostic significance. So I'll repeat. Earlier age of onset, they tend to be men, more poor premorbid function, have more evidence of structural brain abnormalities, they have more prominent negative symptoms, more cognitive impairment, and they have a poor prognosis. So the age of onset has pathophysiological and prognostic significance. The earlier age of onset tends to be for men. Later age of onset tend to be women. They have less evidence of structural abnormalities, they have less cognitive impairment, and they have a better prognosis. Possible risk factors are genetic loading, first order relative with schizophrenia. There's prenatal exposure to flu or virus, there's prenatal malnutrition, obstetrical complications, and CNS infection in early childhood. Prevention and screening. At-risk family education, community education, stigma reduction, signs and symptoms of illness, treatment potential for control of symptoms, early recognition, intervention, and initiation of treatment. Significant and protracted prodromal symptom period usually noted before the full onset of the illness. Usually mild manifestations of criteria symptoms are odd or unusual beliefs, but not to the delusional proportion, feeling unliked or picked on, but not to delusional proportion, odd speech patterns, but not illogical, digressions, tangentiality, and overly concrete or abstractive. Part of the previous slide should have also been odd behavior, but not disorganized, and collects odd or worthless items, mumbles to self, isolates self, and avoids interaction with others. Assess for the following. There exists no single pathognomonic symptom of schizophrenia, but rather a constellation of symptoms. Schizophrenia is a disease of information processing. The symptoms are behavioral and cognitive. The illness is associated with marked social and occupational functioning, or poor social and occupational functioning. Anyway, prominent dysfunction exists in many spheres of daily living. Interpersonal relationships, there's 60 to 70% of clients with schizophrenia do not marry. Social occupational functioning, there's a downdrift of functionality being noted over time. There's lower academic achievement compared to unaffected siblings, difficulty holding a job, and underemployed relative to intellectual capacity. Self-care deficits such as poor hygiene, difficulty with financial management, and limited independent living skills. Characteristic symptom clusters for this illness are positive symptoms, negative symptoms, and associated symptoms. The DSM-5 diagnostic criteria for schizophrenia, it talks about having hallucinations, delusions, and disorganized speech for a 1 month period, but that's a bit confusing because the duration of the symptoms do have to last for 6 months for the person to be able to have that diagnosis of schizophrenia. I know it is part of the diagnostic criteria, but I'm just going to omit it from my memory so I could remember that 6 months is the symptom duration for criteria for diagnosis. Positive symptoms of schizophrenia are disorganized speech, disorganized thinking, delusions, or hallucinations. The explanation here, it says positive symptoms are symptoms that respond positively to and that can be controlled by antipsychotic medication. They reflect excess or distortions of normal brain functioning. They're caused by increased dopamine in the mesolimbic pathway. Positive symptoms are caused by increased dopamine in the mesolimbic pathway. Clinical manifestations are hallucinations, delusions, referential thinking, disorganized speech or behavior, hostility, grandiosity, mania, and suspiciousness. Negative symptoms are symptoms less responsive to antipsychotic medications but respond better to atypical antipsychotic medications. They represent a decrease or a loss of normal functioning caused by decreased dopamine in the mesocortical pathway. So the positive symptoms are increased dopamine in the mesolimbic, but the negative symptoms are caused by decrease of dopamine in the mesocortical pathway. And they are all the A's. So affective flattening, alogia, however one pronounces it, a of speech, evolition, apathy, abstract thinking problems, anhedonia, and attention deficits. Other associated symptoms of schizophrenia are symptoms that not required to be present to diagnose the disorder, but that often are present and a focus of treatment. That's inappropriate affect, dysphoric mood, depersonalization, derealization, and high anxiety. The course of illness is variable. Many clients have a fairly stable illness course. Some clients have clear episodic remissions and exacerbation periods. Negative symptoms tend to appear first as the illness develops. Positive symptoms appear to decrease over time, but negative symptoms persist. Negative symptoms are more debilitating. Factors predictive of good prognosis are high level of premorbid functioning, acute onset, later age of onset, clear precipitating event, married or partnered, a good support system, positive symptoms, short interval between treatment and onset of the first symptom. The sooner the client is treated, the better the prognosis. The longer untreated premorbid period is associated with poorer prognosis. That's with a lot of diseases. Absence of structural brain abnormalities, family history of mood disorders. It says family history of mood disorders. Maybe that's because I have no idea. No family history of schizophrenia. So those are all protective factors. Subtype identification is of limited clinical value because illness course, response to treatment, and prognosis appear unrelated to the subtypes. So there used to be subtypes, but this is no longer. And there used to be paranoid, disorganized, catatonic, undifferentiated, and residual. So it says here subtypes are no longer diagnosed in this DSM-5. Okay. Physical exam findings on schizophrenia. There's abnormal smooth muscle pursuit eye movements, abnormal saccadic eye movement, and poor eye-hand coordination. The client is identified as clumsy or awkward. The presence of neurological non-localizing soft signs are asterognosis, which is the loss of the ability to judge the form of an object by touch, twitches, tics, or rapid eye blinking, dysdiadokinesia, which is impairment of the ability to perform rapidly alternating movements, impaired fine motor movement, left-right confusion, and mirroring. The presence of neurological localizing hard signs are weakness, decreased reflexes. Other abnormalities that may be noted are highly arched palate, narrow or wide set eyes, and subtle malformations of the ears. Mental status exam findings. The appearance is odd, unusual, or peculiar. The speech is bizarre content, disorganized, tangential, loose associations. The affect is generally blunted, flat, or inappropriate. The mood is blandness or impoverished. The thought process is psychotic, hallucinations, delusions, referential thinking, thought control, insertion, or withdrawal. The thought content is thematically matched to psychotic content, and it may be impoverished. Cognition is illogical, disorganized. Orientation is usually intact. The memory may have impaired short-term memory. The concentration is impaired during acute episodes. Abstraction, usually concrete on formal testing. And the judgment is impaired for self-welfare. Diagnostic and laboratory findings. There's no specific diagnostic lab findings. Abnormalities are noted in structural studies. Enlargement of the lateral ventricles, widened cortical sulci, diffuse decrease in volume of white and gray matter. So there's the diffuse decrease in volume of white and gray matter, decreased volume of temporal lobe, decreased volume of hippocampus, amygdala, and the thalamus. The abnormalities noted in functional studies are hypofrontality, decreased cerebral blood flow and metabolism, and diffuse hypometabolic action in the cortical subcortical circuitry. Differential diagnosis for non-psychiatric disorders are epilepsy, central nervous system neoplasm, AIDS, acute intermittent porphyria, B12 deficiency, heavy metal poisoning, Huntington's disease, neurosyphilis, systemic lupus erythemus, Wernicke-Korsakoff syndrome, and Wilson's disease. Psychiatric disorders or differential diagnosis would be bipolar affective disorder, substance-induced psychotic disorders such as with amphetamines, hallucinogens, alcoholic hallucinosis, barbiturate withdrawal, cocaine, and PCP. Mood disorders with psychotic features are schizoaffective disorder, schizophreniform disorder, brief psychotic disorder, delusional disorder, schizotypal personality, schizoid personality, and paranoid personality disorder. Clinical management. Assess for acuity level. During acute psychotic episodes, the clients may require brief hospitalization to ensure client safety, rapidly stabilize the client's symptom level in a controlled environment, and or monitor treatment adherence with the goal of stabilization and recovery. Clinical management during non-acute episodes occurs most often in the community setting. Pharmacological management. Pharmacological therapy is the primary treatment modality augmented by non-pharmacological treatments. Most clients will require lifelong medication. Client and family education is important for treatment adherence. Adjunctive medications may be used to achieve full symptom control, such as antidepressants, anxiolytics, and anticonvulsants. Atypical antipsychotics, so atypical meaning second generation, they're the primary first-line treatment agents for schizophrenia. They were first introduced in the 1990s. They have fewer significant neurological side effects compared to typical antipsychotic medication. They effectively treat both the positive and the negative symptoms of schizophrenia. They function as serotonin dopamine antagonists, D2 and 5-HT2A blockade. They're expensive, but there are some generic that are available. Yes. fewer clinically significant side effects related to EPS and tardive dyskinesia compared to typical antipsychotics. So atypical antipsychotics can cause EPS. They still can cause EPS, and we'll talk about EPS later, but with a lower risk compared to the typical antipsychotic. So there's lower incidence, and there is lower incidence of tardive dyskinesia, and there's improved compliance with the atypical antipsychotic. The mode of action of atypical antipsychotics is, in addition to the dopaminergic blockade found in first-generation antipsychotics, second-generation drugs capitalize on the interplay between dopamine and serotonin. Serotonin binds to 5-HT2A heteroreceptors on dopamine neurons, thus further shutting off release of dopamine. By antagonizing or blocking the 5-HT2A heteroreceptors on the dopamine neurons, dopamine release in the nigrostriatal, tuberoinfundibular, and mesocortical pathway is enhanced. And we said that the decreased dopamine in the mesocortical pathway was associated with negative symptoms. So by using these drugs, we cause some amelioration of the negative symptoms by using the atypical antipsychotics, and that is due to the 5-HT2A action. The dopamine pathways. These explain both the therapeutic effects and the side effects of the atypical antipsychotics. So we'll talk about these 4 pathways in the context of what the atypical antipsychotics do in these pathways. We're talking about atypical antipsychotics. So in the mesolimbic pathway, they block dopamine, causing a decrease in positive symptoms. In the mesolimbic pathway, the second-generation antipsychotics block dopamine, causing a decrease in positive symptoms. In the mesocortical pathway, the second-generation antipsychotics increase dopamine and this causes a decrease in negative symptoms. In the nigrostriatal pathway, dopamine has a reciprocal relationship with acetylcholine. When serotonin is blocked by the second-generation antipsychotics, dopamine increases, therefore acetylcholine decreases, which causes a decrease of risk of EPS. Tuberoinfundibular pathway. Dopamine inhibits prolactin. The blockade of dopamine by the second-generation antipsychotics cause prolactin to increase, causing galactorrhea and gynecomastia. Hyperprolactinemia associated with antipsychotics may cause sexual problems, galactorrhea, amenorrhea, gynecomastia, and bone demineralization in postmenopausal women not on estrogen. In postmenopausal women who are not on estrogen. Now we will break down the atypical antipsychotics. I will stick to the information that is listed in this book and not add or subtract anything, so that it just makes it easy for me to study what the authors feel is most relevant to this exam. So I'm just gonna go by the book. The first one is clozapine or Clozaril. The usual dosage is 25 to 900 milligrams per day. The common side effects are tachycardia, drowsiness, dizziness, hypersalivation, which is sialorrhea, weight gain, and hyperlipidemia. So a common side effect of clozapine is weight gain and hyperlipidemia. A rare side effect of clozapine is agranulocytosis, myocarditis, neuroleptic malignant syndrome. The comments on this drug is it's the only drug for treatment-resistant schizophrenia. It must be enrolled in the REMS program, is the Risk Evaluation and Management Strategy program. There's a risk for neutropenia, and it is monitored by the absolute neutrophil count, the ANC. The ANC only, not in conjunction with a white blood cell count. That's what it says there. During the first 6 months, weekly. During the second 6 months, every 2 weeks, and then monthly if the ANC is normal. So weekly, bi-weekly, and then monthly after the first year. The ANC levels less than 500 suspend the drug. Clients can be re-challenged if the prescriber determines benefits outweigh the risks. Monitor for myocarditis. There's dose-related seizure risk. there's significant weight gain and risk of diabetes. Rare is hyperprolactinemia. So monitor weight, body mass index, waist circumference, monitor serum lipids and glucose, and assess family and personal history of cardiovascular disease. And that's clozapine or Clozaril. Quetiapine, Seroquel, and is Seroquel XR also. The tablet dosage range is 50 to 800 milligrams per day. Common side effects is sedation and hypotension, orthostatic hypotension. There's weight gain. So all of that is common. Sedation, hypotension, and weight gain, common for Seroquel or Quetiapine. Rare is cataracts or cataract formation is a rare but possible side effect. Some comments are transient and asymptomatic elevation of liver function tests, LFTs, monitor for cataract development, divided doses, usually twice a day or 3 times a day. With quetiapine, there's no prolactin elevation. However, do monitor weight, BMI, and waist circumference. Monitor serum lipids and glucose, and assess family and personal history of cardiovascular disease. So quetiapine, there's sedation, hypotension, possible cataract formation, and transient asymptomatic elevated liver function tests. Olanzapine is Zyprexa. There's the oral form. Zydus is also oral but disintegrating tablet, and Zyprexa Relprev, which is long-term injectable. The tablet, and it also comes in intramuscular injection for acute situations, 5 to 20 milligrams daily. The injection or the long-term injectable is 150 to 405 milligrams every 2 to 4 weeks. Common side effects of olanzapine are sedation, weight gain, hyperlipidemia, elevated glucose, elevated LFTs, and mild prolactin elevation. Long-acting preparation Zyprexa Relprev requires that clients be monitored for 3 hours post-injection due to the risk of post-injection delirium sedation syndrome. So that's something huge to remember. The Relprev long-term injectable requires that the clients be monitored for 3 hours post-injection due to the risk of post-injection delirium sedation syndrome. Some other comments on olanzapine are significant weight gain. Monitor weight, BMI, waist circumference, monitor serum lipid and glucose, and assess family and personal history of cardiovascular disease. Risperidone is Risperdal. Risperdal Consta is a long-term injectable. Tablet, liquid, and there's orally disintegrating tablets for Risperdal. There's side effects are hypotension, galactorrhea, nausea, and vomiting. And it doesn't say if it's common or not common, but I would think that all of that is potentially common. So with Risperdal, there's hypotension, galactorrhea, nausea, and vomiting, nausea and insomnia. The comments are that doses greater than 6 milligrams are associated with a higher incidence of extrapyramidal symptoms. There's less weight gain with clozapine, or there's less weight gain with Risperdal as compared with clozapine or olanzapine. It has the greatest prolactin elevation among atypical antipsychotics. Monitor weight, BMI, waist circumference, monitor serum lipid and glucose, and assess family and personal history of cardiovascular disease. Ziprasidone, Geodone, the tablets are 40 to 200 daily. There's also an injectable form for acute IM for acute treatment. The side effects are hypotension, sedation, dizziness, and rare but possible is a prolongation of QTC interval, skin reaction, drug reaction with eosinophilia, and systemic symptoms, which is DRESS. So QTC prolongation and DRESS are possible with Geodone. It requires QTC monitoring. Avoid co-administration with other drugs known to prolong QT, such as droperidol. And taking with food increases absorption twofold. I think it's 500 calories required. But anyway, use caution when administering with clients at risk for hypokalemia, hypomagnesemia after MI infarction, or with congestive heart failure. Monitor weight, BMI, waist circumference, monitor serum lipids and glucose, and assess a family and personal history of cardiovascular disease. So I want to remember hypotension, sedation, QTC, and 500 calories. Food, you have to take it with food. and it's not high risk for weight gain. Paliperidone is Invega. There's Invega oral, there's Invega Sustenna, which is a monthly injection, and Invega Trinza, which is an Invega every 3-month injection. The tablet forms are ranged from 3 to 12 milligrams per day. The injection is 39 to 234 milligrams intramuscularly, and the 3-month injection is every 3 months, 273 milligrams, or 410, or 546, or 819. So 273, 410, 546, and 819. And those are the milligrams that are injected for every 3 months for the Trinza, Invega Trinza. Side effects of paliperidone are orthostatic hypotension, hyperprolactinemia, GI upset, dizziness, and headache. So similar to risperidone, except for the GI upset, dizziness, and headache. Anyway, comments. All it says is there's extended release that paliperidone is an extended release form of risperidone. Aripiprazole is Abilify. That's aripiprazole. Aripiprazole is Abilify. The dosage is 5 to 30 milligrams. There's an injection for acute situations. There's an IM long-acting, and there's an IM monthly for aripiprazole. I believe it's called Maintena, of course. But anyway, side effects of Abilify are headache, agitation, anxiety, insomnia, somnolence, akathisia, GI problems. So akathisia, anxiety, headache, agitation. The comments are that it is a partial agonist of D2 receptors, so only a partial agonist of D2 receptors. Monitor weight, BMI, waist circumference, monitor serum lipids and glucose, and assess family and personal history of cardiovascular disease. Leoperidone, that's leoperidone, is Fanapt. I have a hard time remembering that one for some reason, but leoperidone is Fanapt. The milligrams for that dose ranges are 12 to 24 milligrams a day in divided dosages. Common side effects are orthostatic hypotension, sedation, and dizziness. That's leoperidone Fanapt. The comments are to titrate slowly due to the alpha-1 antagonist properties. Might be helpful for post-traumatic stress disorder, hyperarousal symptoms due to the alpha-1 blocking. That's leoperidone Fanapt, possibly helpful in PTSD disorder due to the alpha-1 blocking. Monitor weight gain, BMI, circumference, lipid, glucose, family history of cardiovascular. Acenapine Sapris, the usual dose is 5 to 10 milligrams daily, usually, well, it says POBID. And then there's only one form of this drug, and it is sublingual. Side effects are akathisia and somnolence, and the side effects are monitor for weight gain, the same thing as everybody else. Monitor weight gain, BMI, waist circumference, lipid, glucose, and family history of cardiovascular disease. So acenapine is a sublingual medication. Lorazepam Latuda is the dosage range is 40 to 160 milligrams daily. Common side effects are akathisia, sedation, and nausea. The comments are that it should be taken with food to increase absorption and used with caution at low doses in clients with renal or hepatic impairment. And the rest are the same as I just mentioned with all the others about the BMI, lipids, and cardiovascular history. But let me repeat. So Latuda should be taken with food to increase absorption. Used with caution at lower doses in clients with renal and hepatic impairment. Brexpiprazole or Rexulti, the usual dosage is 2 to 4 milligrams daily, usually once daily. The common side effects are akathisia and weight gain. The comments on brexpiprazole are to monitor serum lipids and glucose and assess personal and family history of cardiovascular disease. It was approved in July of 2015. But anyway, brexpiprazole monitors serum lipids and glucose, and the side effects are akathisia and weight gain. Cariprazine or Vraylar are the usual dosage 1.5 milligrams to 6 milligrams daily. Common side effects are EPS, akathisia, GI upset, restlessness, and somnolence. The comments on cariprazine, it says to monitor serum lipids, glucose, and family history of cardiovascular. So nothing aside from that. So cariprazine, Vraylar, common side effects are EPS, akathisia, GI upset, restlessness, and somnolence. Aripiprazole Laroxil is Aristada, which is a once a month IM injection at 441, 662, or 882 milligrams. The only side effect listed here is akathisia for common side effect, and it says the same thing as everyone else: lipids, glucose, and family history of cardiovascular disease. Typical antipsychotics, first generation, are cross-classified as neuroleptics because of significant side effects. They were first introduced in the 1950s. Useful for the treatment of positive symptoms by blocking dopamine in the mesolimbic pathway. They can make negative symptoms worse by blocking dopamine in the mesocortical pathway. Therapeutic effect is relatively primarily to D2 receptor blockade. There are various generic available, and that makes them inexpensive and can be used as sustained-release injectable agents. Now we're going to break down the typical antipsychotics, and we'll start with chlorpromazine or thorazine. The usual dosage is 50 to 2,000 milligrams a day. For thorazine, the side effects are sedation, hypotension, there's moderate risk of EPS, and anticholinergic side effects. And the comments are there's possible allergic dermatitis, photosensitivity, EKG changes, and so we monitor QTC, and that's thorazine, chlorpromazine, thorazine. This one I have not worked with, Serentil or mesoridazine. The usual dosage are there's tablets or liquid and injection, and the dosage ranges from 100 to 400. Side effects are high risk for anticholinergic sedation, hypotension, and there's low risk for EPS. Comments: ECG changes or QTC monitoring. Thioridazine or Mellaril, there's usual tablet and liquid dosing are 550 to 800. Side effects are high risk for anticholinergic sedation, hypotension, and prolonged QT interval, and there's low risk of EPS. Under comments for thioridazine, it says ECG changes, QTC monitoring, and irreversible retinal pigmentation at doses greater than 100 milligrams daily. It can also cause decreased libido and retrograde ejaculation. That's thioridazine, Mellaril. Irreversible retinal pigmentation at doses greater than 100, decreased libido, and retrograde ejaculation. For the following three drugs, I didn't find too much of a difference in what the book was saying about these, so I'm just going to group them together. So fluphenazine, which is Prolixin, perfenazine, which is Trilipon, and trifluoperazine, which is Stelazine. All of these have less risk of anticholinergic effects and very high risk of EPS, and it says very high risk. Haloperidol, Haldol, it comes in liquid, injection, pill, of course, and then there's also a monthly decanoate. There's very high risk of EPS. There's also high risk for anticholinergic sedation. There's low risk for hypotension. And in older adults, monitor for ocular crisis and pneumonia. I didn't realize that there was a specific higher risk for older adults for this, but I'm definitely going to mention it because it's listed in the book. So in older adults, monitor for ocular crisis and pneumonia in the context of haloperidol. Molindone or Moban, it comes in tablet and liquid, high risk for EPS, low anticholinergic effects, and the only thing that stands out is that there's little or no weight gain. For Molindone or Moban, little or no weight gain. Thiothixine or Navaine, it comes in capsule, liquid and or injection, and high risk for EPS and low for sedation. So that falls in line with fluphenazine, perfenazine, trifluoperazine, and loxapine are all high risk for EPS and low anticholinergic effects or sedation. Alright, so I got creative with the pictures here. They're helpful to me. If they're not to you, just obviously ignore them. So high potency versus low potency. So high potency have a greater risk of EPS, but less risk of sedation and anticholinergic symptoms. Low potency drugs have a greater risk of sedation and anticholinergic side effects, but less risk of EPS, low potency. And on the slide, I attempt to explain how I remember what it means to be a low potency drug versus a high potency drug. So basically it takes less to cause a bigger effect. As opposed to low potency drugs, it takes more to cause the same effect. Now we'll break down the extrapyramidal side effects, or EPS. And when I think EPS, all I think about is movement disorders, or a movement issue. Akathisia is motor restlessness or an inability to remain still, rocking, pacing, or constant motion of unilateral limb. Also can manifest as a subjective sense of restlessness without objective finding, often mistaken for increased anxiety. Akinesia is the absence of movement, difficulty initiating movement, subjective feeling of lack of motivation to move, often mistaken for laziness or lack of interest. Dystonia is muscle spasm or spasticity of muscle groups, especially in the back or neck muscles, subjectively painful. Note, it's often mistaken for agitation or unusual stereotypic movements characteristic of schizophrenia. Pseudoparkinson's is the presence of symptoms of Parkinson's disease produced by D2 blockade. It includes a shuffling gait, motor slowing, mask-like facial expression, pill rolling, hand tremors, and muscle rigidity. Mask-like facial expressions are often confused with affective blunting or flattening. Tardive dyskinesia is involuntary abnormal muscle movements of the mouth, tongue, face, and jaw that may progress to the limbs and can be irreversible, and they can occur as an acute process at initiation of medications or as a chronic condition at any point during treatment. So that's interesting. So tardive dyskinesia can occur as an acute process at initiation of medications or as a chronic condition at any point in treatment. So let's see. Okay. Tardive dyskinesia is potentially irreversible movement disorder that may occur in people who are treated for more than 1 year with typical antipsychotics. Symptoms consist of abnormal involuntary movements such as lip smacking, chewing, tongue protrusion, or twisting movements of the trunk or limbs. Perioral movements are most common. Treatment involves discontinuation of the offending agent and starting an atypical antipsychotic or switching to an atypical antipsychotic. Because of the multiple clinically significant side effects associated with typical antipsychotics, they're not considered first-line treatment agents. Side effects leading to poor adherence, high client teaching needs. Moving on to EPS monitoring. So extrapyramidal side effects, the most common side effects are caused by D2 receptor antagonism. That is, when dopamine receptors are blocked, acetylcholine increases, which causes EPS. A reciprocal relationship exists between acetylcholine and dopamine. Treated by use of anti-Parkinsonian drugs, which we'll go over in a moment. So, and these classifications are anticholinergics, antihistamines, dopamine agonists, so we're giving dopamine back, and benzodiazepines. Risk factors include long-term treatment with neuroleptics, older age, female gender, and the presence of a mood or cognitive disorder. So those are risk factors for developing EPS. Clients on typical antipsychotics should have routine abnormal involuntary muscle movement screening every 6 months. Every 6 months. Client and family education on the detection of early signs and symptoms of abnormal movements. If abnormal movements are noted, consider reducing the dosage or switching to an atypical antipsychotic. Assessment of abnormal movement rating scales are Abnormal Involuntary Movement Scale, or AIMS, Dyskinesia Identification System Condensed, which is DISCUS, or Simpson-Angus Rating Scale, or SAS. Medications used to treat EPS. The book just lists them. So the first 1, 2, 3. The first 4 are targeted for all of the EPS symptoms, and that's cogentin, which is benztropine, which is an anticholinergic. Chemedrine, that starts with a K, it's an anticholinergic. Artane, which is trihexyphenidyl, anticholinergic. And Benadryl diphenhydramine is an antihistamine. Now, the following medication is just for akinesia and pseudoparkinsonism. So, Symetril, amantadine, is a dopamine agonist. According to this chart, it is good for akinesia, so the lack of movement, and pseudoparkinson's. That's a dopamine agonist. The following 4 medications are going to be specifically and just for akathisia. A couple of them, the 2 benzodiazepines, are for dystonia as well. But all 4 of them are for akathisia. And that's Inderal, Catapres, Klonopin, and Ativan. So Inderal is propranolol, which is a beta blocker. Catapres is clonidine, which is an alpha-2 agonist. Klonopin, clonazepam, and obviously Ativan, lorazepam are both benzodiazepines. Now, the 2 benzodiazepines are good for both akathisia but also dystonia. Neuroleptic malignant syndrome, NMS. It's a rare but potentially life-threatening. It can occur at any point during treatment. Most common with typical, but has been reported with atypical antipsychotics. Risk factors for developing NMS are rapid dose escalation, the use of high-potency typical antipsychotic, parenteral administration of antipsychotics. Assess for the following abnormal lab values. There will be in NMS, there will be an elevated CPK, which is a creatine phosphokinase, elevated white blood cells, and elevated LFTs, which are liver function tests. The first symptoms known to occur with NMS, the first symptoms are altered sensorium, hyperthermia, and hyperreflexia. Assess for symptoms of autonomic instability such as hypotension, extreme muscular rigidity, hyperthermia, tachycardia, diaphoresis, tachypnea, and coma, and potentially death. The treatment for NMS is seek immediate medical care for treatment, discontinue the antipsychotic medications, administer dantrium or dantrolene as a muscle relaxant, and or parlodel bromocriptine for antipsychotic-induced dopamine receptor blockade, and that's because bromocriptine, parlodel, is a dopamine promoter. Other common side effects related to the effects on receptors other than dopamine are alpha-adrenergic blockade, cardiovascular side effects, orthostatic hypotension. The muscarinic cholinergic blockade is dry mouth, blurred vision, constipation, and urinary retention. The endocrine side effects are weight gain, increased prolactin levels. Neurological side effects are lowering of the seizure threshold. Other side effects are photosensitivity and agranulocytosis. Non-pharmacological management is individual therapy, usually supportive rather than insight-oriented, focuses on establishing reality testing, builds daily life skills, assists the client in establishing and meeting life goals. Cognitive behavioral therapy would be for the management of hallucinations and delusions. Group therapy could focus on problem solving, focus on education, medication groups, and life skills groups. Group therapy could help the patient with life skills groups. Proactive crisis management planning to deal with the potential relapse needs is definitely something that needs to happen with patients with psychotic disorders. And they include identifying symptom triggers and symptoms that indicate relapse, patterns of relapse that help predict future relapses, self-care interventions, identify the point at which professional intervention is required, and identify the support network of the family or friends, and also resources to be mobilized when symptom levels increase. Some examples of evidence-based crisis management programs are Assertive Community Treatment, or ACT, which is an evidence-based case management program that involves a multidisciplinary treatment team. Then there's also Illness Management Recovery, or IMR, which is an evidence-based recovery program, and education modules with all of the topics relating to mental illness, supports, group medication, coping, reducing relapse, and so on. Common comorbidities, rates of substance abuse and dependency are very high with people with schizophrenia, 20 to 40% comorbidity at 20 to 40%. Nicotine dependence is especially high at 80 to 90% comorbidity. 80 to 90% comorbidity with nicotine dependence and schizophrenia. They tend to use cigarettes with the highest nicotine content also. Drug interaction with antipsychotic medications may need to reduce doses when the client quits or cuts back. nicotine. There's many drug interactions with nicotine and antipsychotic medication, and may need to reduce doses when the client quits or cuts back. May need to reduce doses because nicotine is an inhibitor. So if they're smoking all the while taking psychiatric medication, that's lowering the medication level. So when they stop smoking, the medication levels are going to rise to levels that unexpected high levels. Okay, anyway, so other common psychiatric comorbidities are anxiety disorders, especially panic disorder, and obsessive compulsive disorder. General health considerations. Schizophrenia is significantly associated with a shorter than expected lifespan when compared to the general population. Persons with a severe mental illness prematurely lose 10 to 25 years of their life compared to the general population. Reasons are unclear but may include overall general lack of routine health care and high levels of comorbidity. Suicide. Suicide rates are high. Assess for suicidal ideation at every visit. 10% of people with schizophrenia and psychotic disorders commit suicide. And 20 to 40% of people with schizophrenia and psychotic disorders attempt suicide. Known risk factors for suicide include male gender, age 45 or younger, presence of depressive symptoms, hopelessness, unemployed, noncompliance, recent hospitalization, post-psychotic period, and comorbid substance abuse. Client needs. Assess clients' access to ongoing primary care. High rates of cardiometabolic illnesses. Monitor client for development of metabolic syndrome, diabetes, hypertension, hyperlipidemia, respiratory illnesses, and cardiac illnesses. Monitor weight gain, lipids, and blood glucose. Provide weight management and nutritional assistance. Use the body mass index as the accepted standard for determining if a client's weight places him or her at risk for developing a serious health problem. BMI categories are: underweight is BMI is 18 or less, normal weight is 18 to 25, overweight is 25 to 30, obese is 30 to 40, and severely obese is over 40. Risks related to BMI are clients who are overweight to obese as determined by their body mass index, have 2.9 times increased risk for diabetes and hypertension, coronary artery disease, and 3 times higher risk for endometrial cancer and colon cancer. Lifespan considerations. Children. Hallucinatory and delusional content is less rich, elaborate, and bizarre. Visual hallucinations are more common in children than auditory. With older adults, late new onset psychosis is more common in women. The prognosis is still usually better. Some risk factors are postmenopausal states, presence of human leukocyte antigen, and positive family history. For follow-up, it's a chronic illness and it usually requires lifelong treatment. Case management may be necessary to coordinate aspects of care. There are periods of relapse, so develop a relapse plan with the client and the family. There's going to be multiple health needs, so perform frequent assessments of general health status and address comorbid nicotine addiction. Preventative care, monitor routine labs to screen for complications of treatment, monitor serum glucose and lipids, weight, BMI, waist to hip ratio, liver and kidney function based on the medication, complete blood count, and perform annual eye exam if on a typical antipsychotic agent or Seroquel. So I'll repeat that. Perform an annual eye exam if on a typical first-generation antipsychotic agent or Seroquel. Standardized ratings for clinical outcome measures. There are standardized rating scales, and they include the Positive and Negative Syndrome Scale, so PANS, or Brief Psychiatric Rating Scale, BPRS, or Scale for Assessment of Positive Symptoms, SAPS, or Scale for Assessment of Negative Symptoms, SANS. Now we'll talk about some other specific disorders. So there's schizophreniform disorder. This closely resembles schizophrenia. There are two differences from schizophrenia. The total duration of the illness is at least 1 month, but less than the 6 months required for schizophrenia, including the prodrome, active illness period, and residual symptom phase. And it does not require impaired social or occupational functioning for the diagnosis, although these may be present. Assessment. There's 2 or more of the following frequently present during the 1 month period: delusions, hallucinations, disorganized speech, disorganized behavior, and the presence of negative symptoms. The duration of the symptoms have to be at least for 1 month, but for no longer than 6 months. Almost all the information provided for schizophrenia pertains to this disorder, except it occurs much less often than schizophrenia, with an incidence of 0.03% of the general U.S. population. Approximately 1/3 recover completely within 6 months, and the remaining 2/3 go on to develop schizophrenia or schizoaffective disorder. The rest of the topics, such as physical exam findings, mental status evaluation, diagnostic and laboratory findings, clinical management, and so on, all are the same thing as for schizophrenia or similar. Schizoaffective disorder is an uninterrupted period of illness in which the person experiences psychotic symptoms similar to those seen in schizophrenia, as well as mood symptoms similar to those seen in major depressive disorder. The etiology, the cause is unknown. The disorder may be a psychotic spectrum disorder or a mood spectrum disorder, or both. The prevalence in demographics is less than 1%, equal number males to females. Depressed type of the disorder is more common in older persons, and men with the disorder tend to exhibit more antisocial behaviors. Risk factors are family history of schizophrenia or bipolar disorder. Prevention and screening are screening persons with a positive family history. For the assessment, assess the following: symptoms of schizophrenia with 2 or more of the following frequently presenting during a 1 month period: delusions, hallucinations, or disorganized speech or grossly disorganized behavior, and the presence of negative symptoms. Symptoms of 1 or more of the mood disorders: major depressive disorder, manic, or mixed episodes. The presence of delusions or hallucinations for at least 2 weeks in the absence of prominent mood symptoms. There are 2 subtypes of schizoaffective disorder. The 2 subtypes are differentiated by the type of mood-related symptoms, such as depressive, which is so it would be schizoaffective depressive type. That's when the prominent mood symptoms are of the depressive type only, or schizoaffective disorder bipolar type, when predominant mood symptoms are manic or mixed type. And the rest of the topics are similar to schizophrenia. Delusional disorder is the presence of 1 or more non-bizarre, so non-bizarre meaning they're potentially believable, delusions lasting for at least 1 month. The psychosocial functioning and daily behavior is not at all impaired, except as they surround the content of the delusion. Seldom any other symptoms, and in rare cases may have hallucinations or mood disturbances. The etiology of delusional disorder cause is unknown. The prevalence in demographics is 0.2% to 0.3% of the population in the United States. The mean onset is about 40 years of age. Men are more likely to have paranoid delusions, and women are more likely to have delusions of erotomania. The risk factors are persons with disorders of the limbic system and basal ganglia. Are risk factors for delusional disorder are persons with disorders of the limbic system and basal ganglia. The assessment is assess for the presence of delusions, which are well organized and potentially believable. That makes them non-bizarre, right? Well organized and potentially believable. Any unusual behavior is explainable if the content of the delusion is understood. Subtypes are categorized by thematic content of delusion. The subtypes of delusions are delusional themes are erotomatic, grandiose, jealous, persecutory, somatic, and mixed. Erotomatic is the delusional content focuses on false belief that another person is in love with a client, usually focused on idealized or spiritual love, and only infrequently has a strong sexual content. The focus of love is usually a famous or powerful person who does not usually know the client. In rare cases, persons may know the client, and this leads to obsessive behaviors such as surveillance or stalking. Grandiose delusional content focuses on the client having some great talent, skill, or knowledge, may have strong religious components such as a prophecy or a deity or connections to a god. Jealous delusional themes are delusional content focuses on false belief that the client's spouse or partner is being unfaithful with somebody else. The belief has no connection with realistic evidence, usually seen in men. Client may try to control behavior of the spouse or partner in an attempt to prevent imagined infidelities. Persecutory are delusional content focuses on the client's beliefs that others are out to harm them, spy on them, or otherwise cause harm to them, often angry and hostile at the perceived persecution. Delusional disorder, somatic delusional themes are the content focuses on bodily functions and sensations, often the belief that a body part is infected, absent, or emits a strange odor, or is misshapen or malformed. Mixed delusions are there's no clear predominant theme for the delusional content. The related symptoms that can be present but are not required for diagnosis of delusional disorder may become depressed over protracted problems with thematic content, may become involved in legal difficulties related to the behaviors based on the delusional content, or may be subjected to or request unnecessary medical tests and procedures related to their delusional thoughts. The mental status exam for a person with delusional disorder is normal except for the delusions. Abstraction may be concrete on proverbs only during the delusional episodes. Thought process is the presence of delusions, perseverations on topics related to the delusion. Thought content would be the thematic for the type of delusion. There's no specific diagnostic and laboratory testing, and all of the rest of the topics are similar to schizophrenia. Brief psychotic disorder. This disorder is with sudden onset of psychotic symptoms lasting at least 1 day but less than 1 month. Etiology is unknown. Incidence and demographics are unknown. It does say it occurs more in younger clients. That's brief psychotic disorder between the ages of 20 and 30. There is a possible risk factor with family history of psychotic disorder. There's prevention and screening is unknown. And then the history, it says age of onset in adolescence or early adulthood for brief psychotic disorder. There's positive type psychotic symptoms such as delusions, hallucinations, disorganized speech, disorganized behavior, and can occur with or without an identified stressor. The person always returns to pre-morbid level of functioning in the context of brief psychotic disorder. That makes it brief. It's just 1 month and then it goes away, or less than a month. At least 1 day, but less than a month. To reiterate, with brief psychotic disorder, the person always returns to pre-morbid level of functioning. And so I continue my race to study for my board exam, and this completes probably one of the heaviest chapters in the book, the psychotic chapters. And since I skipped and I already completed the substance abuse chapter, then there's not much left. The next video will be about neurocognitive disorders and disorders of childhood and adolescence.